So I'm Joan Neuner, and I'm going to be speaking to you today about a very early stage P20 project titled Development of a Women's Incontinence Registry. And this really is a very collaborative project with members of our team from primary care to subspecialties in urogynecology and urology, informatics, and population health. So I'd like to highlight a few of those members. My name is Joan Neuner. I am an general internal medicine physician with experience in health services research. And I am the research program lead on this project, but Dr. Catherine Flynn is the overall and administrative P20 PI and has been instrumental to this project. She particularly brought her skills as an investigator on some of the GU Promise work and the Learn Investigator, and really is quite expert in how to measure patient reported symptoms and outcomes. As I mentioned, we also have urologists, urogynecologists, informatics, biomedical engineering, and health policy. And crucial to this work has been our interactions and collaborations with members of our health system. I don't have to tell this group anything more than they've heard in the last 2 days about how distressing incontinence can be for patients generally. But for US women, over 30% of women over 50 report bothersome incontinence of stress, urge, or mixed types. And that risk is further increased with chronic conditions that are usually managed in primary care, such as diabetes. But there are gaps in understanding of what happens from that primary care to specialty care or to adequate care in primary care, that they don't seem to have this managed well. And notwithstanding some really great work from some members of the UroEpi group that have presented in the last couple of days, there are few longitudinal studies of treatment patterns, barriers, or outcomes in incontinence in primary care. So two of the aims of our research project that I'm going to be talking about today were first to examine the feasibility of routine measurement of patient-reported urinary incontinence in a primary care-based population. And second, to utilize this measure of UI and other elements from a health system's clinical data to establish a registry to study incontinence healthcare utilization and outcomes. And the methods for this work really were driven in part by information and some data from a study that was presented last year at Caribou by Ericsson's team. This study was a study that used linked information. My lab has a lot of experience with using Medicare and other large data sets. And this study combined data from Medicare fee-for-service, that's what the FFS stands for, with survey information from the Nurses' Health Study. So many of you know that's a very large longitudinal study of nurses who provided information to the Harvard group for over 20 years. So these women are now in their 60s at the youngest. They actually have apparently daughters of some of the nurses in the study now. And they found 34,000 patients in that data set who reported about incontinence on their survey and were linkable to their Medicare claims and willing to let the researchers link that data to their survey outcomes. And so similar to what I've said earlier about how common urinary incontinence is in older patients, in those 34,000 women, 18,000 of them reported urinary incontinence. But unfortunately, the researchers also reported that when they looked at those linked data from Medicare to try to find diagnoses in visits in the year after the patients reported incontinence, they could only find evidence of outpatient visits for urinary incontinence for 3,000 patients, while there were no visits for urinary incontinence for 15,000 patients. So what that meant for me for the work we were starting to build is that for 84% of patients, if we used information from diagnoses on billing-based records or something like an EHR, where most of the diagnoses come from outpatient billing done by providers, that we would be missing a lot of patients with incontinence. And we didn't want to do that. So our team that was, as I told you, was quite collaborative and multidisciplinary, got together and thought about how could we do this a little bit differently. And particularly, how could we leverage what we were already seeing happening in our health system? And specifically that our health system already appeared to have a single item screen for urinary incontinence that they were using at many, but not all, of preventive primary care visits. And our rationale for moving in this direction was that UI screening already appeared to be occurring, and we found evidence for that that they were, by assembling a lot of paper yearly preventive visits. One of our medical students visited 24 clinics and collected all the paper preventive visit and physical forms. And we also surveyed some of the other systems in southeastern Wisconsin and found that nearly all asked about urinary incontinence on at least some of their forms that they used for at least some of their patients, and particularly women. Now, we understood that screening only among those who attend preventive visits, rather than at every single visit, for example, as happens in my clinic for asking patients about falls, reduces physician burdens and perhaps patient complaints about being asked the same thing over and over again. But there are some limitations as well, specifically some potential selection bias, so that we may not be identifying all of the missing 84% because not all patients might be coming for preventive visits. Some might only be coming for urgent or problem-based visits. Nevertheless, we decided to take a deeper dive into this and see if we could understand how helpful using a patient report would be in trying to find more of our patients who reported incontinence so that we could study their care. First of all, we actually asked, why isn't screening happening widely and why isn't it easy to see in the charts? And it actually appears to be somewhat controversial in primary care right now, notwithstanding that it's been part of the review of systems that all clinicians are taught from the moment they enter medical school to ask about urinary incontinence. But right now, no current primary care group, probably because they don't have strong evidence that screening leads to better outcomes than not screening or case finding. So right now, there's only one group called the Women's Preventive Services Initiative that strongly recommends screening for everyone in primary care. Nevertheless, we saw a lot of evidence. I already told you that it's happening all over the place, but perhaps not systematically in our health system and others in southeastern Wisconsin, at least. But we did see that it seemed to be happening most consistently in something called the annual wellness visit. For those of you who aren't primary care, which is almost all of you I know, this is actually the Medicare physical. And my Medicare patients always tell me when I talk to them about their annual wellness visit, well, that doesn't sound like a physical at all, because really what it is a prevention discussion. And it's focused on proactively addressing modifiable health risks, including functional decline. And it actually can be done essentially on paper and with a discussion with patients and a vision screen. So it's really very little hands-on patient, very different from what patients expect for a physical. But it does have a series of requirements that patients need to be asked because there is some evidence, and this is a Medicare quality measure, that's really working to individualize patients' modifiable health risks and try to make specific plans to reduce their functional decline can do so. So it specifically requires that patients ask about toileting, but not incontinence specifically during a review of dependence and activities of daily living. And perhaps because of that, our health system already was using a question about urinary incontinence in all of their tools that they recommend for annual wellness visits. So they had, it was in all their paper intake questionnaires, but we did find that not every clinic was using the paper intake questionnaires, even though they all reported they thought they had at one point. And then because these are such prescriptive visits, nearly all clinicians actually use these digital templates that allow you to just cut and paste in responses to questions if you're asking the patient rather than using a paper questionnaire. And in fact, you have to do some entry regardless of whether paper questionnaire was available because it's a digital note that you're writing. And there was a question about urinary incontinence. Essentially, do you experience urinary incontinence, with no questions about the timing of that. It was already in one of our digital templates that I use every week for my patients as I do these preventive visits. But that didn't mean I could make everyone in the entire health system use the question that I preferred or make sure it was happening in all our primary care visits. Luckily for us, we were able to leverage our learning health system's priorities. So what I mean by learning health system, I address, if you're interested in more reading about it, the AHRQ really advocates thinking about how you can measure things and measure in the systems where your patients are currently getting care and hopefully improve care for the patients at the same time. And our institution our health system has been really interested in sort of following some of the recommendations. But what that usually means is some compromises and really working to figure out how you can both have a win-win and work in priorities of your health system. So just a word about our health system. It's like a lot of academic health systems. It's a one hospital or actually just recently grew to 3 hospital health system with 24 affiliated primary care practices that range from fairly rural to suburban and a couple of more urban. Cared for in 2019, approximately 150,000 established female patients. And conveniently for us, partly to fulfill agreements with insurers who wanted, because it improved their Medicare quality measures on their internet scores, to ensure that more patients were getting Medicare annual wellness visits. I think our health system also thought they were good for patients, but the timing worked well that they were working with some of the insurers at that point. And they were already planning actually to enhance our care by turning those paper forms into online ones, which again, very conveniently and importantly for us, meant it was going to be much easier to put into a registry and use for research. We had to draw on all of our key contacts and collaborators for this work. So Brad Crotty, as I mentioned, was a team member. He's also a general internist, but an informaticist who leads our health system's digital engagement. We have also worked very, very closely with other representatives of our health system who weren't formally on our team, including the physician director of population health. I've had so many conversations with primary care practice leads and medical directors and other members of our population health team.
You have about 1 minute remaining. Thanks
so much. And just a few more thoughts about what went into this then. We, as a team, examined options for single or multi-item measures because we hated people just being asked, do you have incontinence? And developed a 1-item, initially developed a 3-item measure. And then we're told by the system that no, we couldn't have that much space in their pre-visit questionnaire. And so had to compromise down to one item. And then we negotiated further with the health system to make sure that for anyone who wasn't using a patient portal, which is how these electronic questionnaires were going to be entered, that the template that the physicians use would ask the exact same question. And this is what the question is, worded below. These are some of our planned outcomes. So I have 2 slides that hopefully will make you want to join with us as we start to develop some of our results. So first of all, we're just going to start out with feasibility and generalizability measures. Does this work? Do patients fill these out? Do the clinicians fill them out? And then how representative are the patients who do that annual wellness visit compared to other patients? Because we will have information on all the primary care older women's patients in our EHR and can compare, for example, demographics and comorbidities. These are some examples of what we expect to find. It appears from work in 2019, just prior to the pandemic, so when patients were still coming in for visits, that about 15% of established primary care visits do get one of these annual wellness visits at our system, just a little lower than the national. And these are some of the demographics and comorbidities of patients, older women in our system. So we hope to work with some of you perhaps in the future to leverage the registries and examine questions as we've outlined in our P20, like the percentage of patients who report urinary incontinence. So confirming that Erickson work, but using different methods, factors that are associated with incontinence in the primary care settings, and the prevalence and perhaps equity of current incontinence healthcare. As you heard yesterday from Dr. Davidson, for those of you who are able to attend hers, we're also planning to test a pilot dissemination and implementation study that will leverage our ability to identify patients with incontinence and improve a pathway to their care, and also to use perhaps as a sampling frame for other generalizable future studies. So we hope you'll help join with us in potential future studies like the ones we have outlined on this slide. And thank you very much.